As Rajlakshmi said, today we are going to learn about one of the nursing issues, which is on lymphedema. That session will be taken by Sister Sreedevi. She is a BSc nurse. She has more than 5 years of experience in palliative care. She is the charge nurse of inpatient facility. Sreedevi, welcome and over to you.
Good afternoon, all. About lymphedema. So I think all of you know about lymph. Can you tell anyone about lymph? Okay, the lymph is a tissue fluid or interstitial fluid is collected through lymph capillaries, then enters into the lymphatic vessels to lymph nodes. It contains protein, lipids, and water. It is like an interstitial fluid. It will contain protein and lipids. Mainly the protein and lipids are the main part of the lymph fluid. It can separate nodes and separate vessels for carrying the lymph fluid. And the lymphatic system has different functions. The main function is the reabsorbs excess interstitial fluid. Second one is transport of dietary lipids, and other one is lymphocyte development and the immune response. I think all of you know about the lymphocyte development and immune response. The main function of the lymphatic system is the immune response. Whenever any infection or inflammation happens in the body, the surrounding lymph nodes are the indicators. Did you know what this means? It is the systemic circulation of blood. In this, we can see the two parts of body and upper part and lower part. In upper part, the superior vena cava will circulate the blood all over the body, and lower side, the inferior vena cava will collect the impure blood to the left atrium, and purification will processing, and aorta will collect from this area and supply to the all over the body. This is the another circulation of in the body. It is called as lymphatic circulation. Lymphatic circulation arises from the communication of venous system and arterial system. At the time of the communication, some sort of fluid will be leaking through this area. It will be collected by the blunt-ended capillaries. It is called as lymph capillaries. The green color shows lymph capillaries, blue color is venous system, and red color is arterial system. This is the structure of lymph capillaries. It means the blind end. It has no opening system. It is closed circuit. Single layer of overlapping endothelial cells, more permeable than the blood capillaries. These are the importance of lymph capillary structure. These are the site of lymph nodes. The lymph capillaries has main part is called as lymph nodes. This will be located mainly in the joint region like axilla, neck region, abdominal region, inguinal region, cervical region. Mainly we are seeing in the axillary region and inguinal region. This is the circulation of the lymph fluid. From the lymph capillaries, it enters into the lymph vessels and then into the lymph node. The lymph node will be enters into the lymphatic vessel. It then passes through the lymph trunk and collecting duct. The collecting duct is opened into the subclavian vein. So the lymphedema is our topic. Did you know what is lymphedema?
Any answers?
The name itself, it's a edema. It is the swelling of interstitial tissue as a result of lymph drainage failure when capillary filtration is normal. Capillary filtration is the capillary filtration is in normal. The drainage failure happens because of any obstruction or any trauma. It will cause the accumulation of fluid in the interstitial tissues. So it will cause the swelling of that area. It is called as lymphedema. Mainly it has two types, primary and secondary. Primary means congenital lymphatic dysplasia, means in the birth itself the baby has any congenital anomalies present. So there is a lymphatic obstruction, that is called as primary. And secondary means anatomical obliteration of lymphatic system. In the lifespan, anything happens to the lymphatic system like road traffic accident, any surgeries, it will causes the lymph node damage. It will cause the lymphedema. This is called as secondary. In secondary lymphedema, there are two types, malignant and non-malignant. Non-malignant means trauma like RTA or burns, infection like cellulitis, iatrogenic and radiotherapy. Iatrogenic means surgery. We know that any total mastectomy and all we are doing means at the surrounding lymph nodes also we are removed. So that's why there is further happening means in lymph system also damaged due to the lymph node removal. So there cause the lymphedema. Malignant means lymphomas. Lymphomas means any cancer occurred in the lymph nodes. And secondary reoccurrence. The primary is maybe the primary is in any other part of the body, but secondary reoccurrence will be happens in the surrounding lymph nodes. That is called a secondary reoccurrence. How we are diagnosing lymphedema? First thing is history. While doing a history collection, we have to collect these three parts. Unknown cause, any known cause is there. Suddenly the lymphedema happens or not, like that. Disease or trauma, previous or past history of disease or trauma will happen to the area. Any treatment related, any treatment has to be going on before that, like radiotherapy or surgery, something like that. We have to collect during the history collection. Next thing is clinical examination. This is the pitting edema test. It has two stages. Stage 1. At this stage, the tissue are swollen but are still soft. How did you examine that? First, we have to press on the lymphedema area. Gentle pressure on the swollen tissues. It will cause pitting edema on the lymphedema site. It is called as the pitting edema test. This will be going on in the stage 1st. Then second stage, the tissues have become fibrotic and the tissues are no longer soft. Fibrotic means hardened. There is sometimes small creases also developing. It is not at all soft like first stage of edema. Stage 3, the tissues are considerably hard, cartilage formation. Cartilage formation means it's a hard plaque-like appearances in the skins. And deep creases also develop. This is the sign present in the lymphedema patients. The stemma sign is defined as inability to pick up a fold of skin over the proximal phalanx second toe. That is, normally we can pinch the skin of second toe in the lower extremities very softly. But in lymphedema patient, we can't pinch the skin of second toe because there is the edema accumulation. These are the skin changes. Mainly the skin changes is, we can show in the first picture. It is called as orange peel skin. This is mainly in the first stage of edemas. And deep cases will be in the third stage of edema. And hardened tissue will be there in the third stage. In second stage onwards, the skin will be hardened. But in third stage, more hardened than second stage. These are the other diagnostic methodologies. We are not using these and all. Soft tissue imaging like MRI and CT to determine the extra fluid volume. And another one is lymph vessel imaging to detect the abnormalities. And other one is bioimpedance spectroscopy. The measure, it is used for to measure the interstitial fluid volume. The main it can be divided into further areas for the lymphedema problems. First one is physical. It is mainly the lymphedema causes pain and discomfort. Due to the huge edema will be there, we can't move the hand or leg as per our wish, and impaired mobility and loss of function. We can move our limbs as per our wish. It can cause the impaired mobility and loss of function and discomfort. It will be a hard edema. It will cause the pain. And second one is psychological problems due to the lymphedema. First one is body image disturbance. If the more edema will be there, it will cause the body image disturbance, loss of independence. We will depend others for our doing our daily activities. Loss of change of employment. We can do our jobs satisfied with this edema. Difficulty in wearing clothes and shoes. And anxiety and depression due to the disease condition. Social isolation. From social functions and all we can't do. We can go and participate in the functions because of this edema with bandages and whatever it is. And constant reminder of disease. Sometimes the patient may think that the disease will come back because maybe it will develop after few years after the surgery or any trauma. The management. Mainly we are continuing 4 principles in management. The skin care, massage, compression, bandaging, exercise, and intermittent pneumatic compression. Mainly we are divided into mainly 4 principles, that is skin care, massage, bandaging, and exercises. In skin care, what are the things we have to remember in skin care? If a patient is come with you with a huge edema, as a nurse, what did you tell them about?
Either you can chat or unmute yourself and talk. So when a patient comes with the lymphedema, what are the instruction given to the patient and the caregivers about lymphedema as a nurse? Okay, one answer, keep the skin clean and dry. Very good. Watch for any injury. Anything else? Avoid tight jewelry or clothing. Very good. Next.
First one is apply simple moisturizing cream to avoid the dryness. Because sometimes the edema hand will be very dry. It will cause the skin breakage due to the dryness. Keep the dry clean and dry. Dry means the moist content will be dried out, but moisturizing cream will be there. Meticulous drying between the digits. It's very important because sometimes the skincare will be given with soap and water, but they are not drying between the digits. So this will cause the fungal infection in between the digits. So meticulous drying between the digits are very important role in the lymphedema skincare. And avoid injections and any puncture. If we are doing any punctures in the lymphedema hand, it will cause the oozing of fluid from that side, and also it will cause the entry of the microorganisms into the skin. It will cause the inflammation or infection for the site. And avoid razors, avoid blood pressure cuffs, avoid injury, keep cuts clean and dry, avoid carrying heavy things. This is the measurement. For what purpose we are doing measurement means, if once we are doing any management for the patient, we can identify the management is working or not. So we have to do the measurement once in 1 week or within 3-4 days. So we can change the difference between the difference between happens in the management. So doing measurement, we giving a comfortable position for the patient with arm support on a table. Second one is, we have to, in case of arms, we have to identify the head of ulna. Take 2 centimeters above the head of ulna, and from that point, every 4 points to be noted, and take the circumference of the each and every points. Second principle is massage. In massage, manual lymphatic drainage. This is start with the deep diaphragmatic breathing. It will, because of it will stimulate the all abdominal lymph nodes, and it will stimulate the abdominal lymph nodes and ready to pick up the fluid whatever the we massage and given back, and stimulate the superficial lymph node that are neck, axilla and groin. These are the manual lymphatic drainage. In simple lymphatic drainage, we have to stimulate the unaffected node first, because we have to do 2 parts in affected hand and unaffected hand. First, we have to do the stimulate the unaffected hand, and it will ready to pick up the fluid from the affected side. And massage proximal part first, and then go to the distal part. First, more edema in the proximal part means we have to do the massage in the proximal part first, and then go to the distal part. Use gentle pressure for the massaging, because the lymph nodes and lymph capillaries are present superficially in the skin. So gentle pressure is enough for the massaging. These are the way of massaging the lymph nodes. The simple touch is enough for the stimulation. These are present in the superficially to the skin. Mainly we are stimulating behind the earlobe, in the tonsillar region and supraclavicular region and axillary region. In the condition of upper limb edemas. In lower limb edemas, these 4 points plus in groin region also we have to massage and stimulate. So, next principle is bandaging. It will do teach through the practical section. Next thing is exercise. For exercise, we are doing means we are doing the skin care, massage, and bandaging. After the bandaging, we have to do the exercises. It will stimulate the fluid to pull up and drain through the abdomen. And gentle and regular, it will be gentle and regular. It is done because of prevent the stiffness of the edema site and encourage normal activity. It will stimulate the range of motion exercises. It can be passive and active. These are the intermittent pneumatic compression. It is effective in lymphedema. Due to the immobility, venous incompetence may be there. So it is a electrical air compression pump. It can be used with we can adjust the pressure in that machine. It may be the duration of 30 minutes of interval. The pressure may be 30 to 60 mm of Hg. Did you know the complications of lymphedema?
What are the complications of lymphedema? Infections? Very good. Anything else? Immobility. That is one of the problems. Any other points? Complications of lymphedema. Sore. Okay. Pressure sore. Cellulitis. What is CCF? Yes, okay. Congestive cardiac. I think because of the fluid overload, Sister Willie, it is to think the congestive cardiac failure. Okay. Deep vein thrombosis. Okay, thank you.
First thing is cellulitis. Acute inflammatory episode. What is the difference between cellulitis and lymphedema means? In cellulitis is an inflammation and lymphedema is an obstruction in the lymph fluid drainage. In lymphedema, we can see the cellulitis as complication because the massaging is bad means it will cause the cellulitis. So it is difference between the cellulitis and lymphedema means it is an inflammation, so that is has local rise of temperature will be there, redness will be there, severe pain will be there. So headache and vomiting. In cellulitis, infection, what is that? Infection of skin and subcutaneous tissue. The streptococci is usually also the staphylococci causes the cellulitis. The main symptoms of the cellulitis is pain, swelling, warmth, redness, lymphangitis, lymphadenitis, and blisters. And fever, headache, and vomiting, as same as the signs of inflammation. The first line antibiotic is amoxicillin at least for 2 weeks. If it is not working means we can use the IV antibiotic with the help of the physician. Second main complication is lymphorrhea. Means aurea means crying. The lymph will cry. It is the leakage of lymph from an edematous lymph. Apply for the management is apply no adherent dressing to leaking area. Apply the pressure bandage. So that's why we have to skin care is very must because of any puncture happens for the skin, it will cause the lymphorrhea. So if we noted the lymphorrhea means we have to stop pressure massaging first, and we can do the pressure bandage for the side with the help of adherent dressing.
Thank you, Sister Sreedevi. Any doubts regarding lymphedema management and all? Anybody have any doubts, please ask us. Hey, either you can chat or unmute yourself and talk. Sister Regina? Next week, we have a demonstration on lymphedema management. That time, we will discuss more about the lymphedema management. So, if Sister Mercy Anthony, do you have a question? If nobody have any question, I will ask questions. Okay. What we have to do with the patient who have lymphedema at the side of neck? Usually at the side of neck, we no lymphedema develop. Usually, Sister Brother Vimlesh, can you explain more about that? Okay.
It's not, sometimes the edema will be accumulated in the neck area also. We have to rule out first as cellulitis or lymphedema. Then only we have to manage that. If you can confirm about lymphedema means we can do the simple massage for that area first and massage from the neck area to the back of the neck and to the downwards with the help of moisturizing cream. If the patient is having severe pain, we can use the pain medicines.
I'm sorry, I don't understand the topic very well, but Sister Regina, this is regarding the lymphedema. There is related to lymphatic system. So, Sister Sreedevi was explaining the lymphedema, where the lymph formed and what are the problems of the patients when if lymphedema developed. all those things, and how will we manage the lymphedema when the patients develop lymphedema? How will we manage that part? She was covered. So we need to understand that where the lymph is formed. So in our systemic circulation, we have a upper that our superior vena cava collect all deoxygenated blood, and the inferior vena cava collect all the deoxygenated blood from the lower part of the body. That with the help of pulmonary artery from the left right ventricle, that goes to the right and left lung. So what happened there? So there is a connection between the deoxygenated blood and oxygenated blood. That time that deoxygenated get oxygenated, and the pulmonary vein again collected from the oxygenated blood from the lungs, and goes to the left atrium and then left ventricle. Again the aorta will pass the oxygenated blood throughout the body. And here there we need to understand that there is a communication between the arterial capillary and venous capillary into the lungs for purification of blood. The same thing will be happening into the tissues also. Can you see the slides? Can you share the slides? Yes, here. The next slide. It's okay. The same thing happening into the our tissues also. The same that arterial capillaries and with the union of arterial capillaries and venous capillary. That time there is a leakage of fluid like plasma is escaped. That is called the lymph. So union of lymphatic capillaries and not arterial capillaries and venous capillaries, there is a chance of oozing out of fluid from that area. That is called the lymph fluid. Okay. So that fluid which will be collected by the lymphatic capillary. Okay. That is why she mentioned when she was taking the class, the lymphatic capillaries has a blind end. Next slide. Okay, so blind end single layer, it was overlapping it with the endothelial cells and more permeable than the blood capillary. Okay, if any blood the fluids appear, that fluid will be collected from the lymphatic capillaries. Okay, so next. So we have a lot of lymph nodes in our body. It's around 600 to 700 lymph nodes in our body. Okay, so that fluids once the lymphatic capillaries collect the fluid from the tissues, that will enter the lymphatic capillaries, and again lymph nodes. Next. Lymphatic capillary, when the fluids collected from the lymphatic capillaries again pass through the lymphatic vessel, again that will be segregated into the lymph node, again lymphatic vessel. Finally, it will be collected. It will be collect through the collecting from the collecting duct, then goes to subclavian vein. Again, the systemic circulation. Okay, that is why this is connected to our systemic. This is also a systemic circulation part. Okay, if next. So that is why what is lymphedema? So if there is any damage into we understand that what is the way of passing the lymphatic fluids. If there is any damage into the lymphatic system, like for example, for an CA breast patients, when we do what will we do? CA breast patients, we do surgery on total mastectomy. So when we do the total mastectomy, what happen? So removal of breast, along with that adjacent lymph nodes also we will remove. So if the adjacent lymph nodes removed, who will take care of that lymphatic flow? So there is a obstruction there, no? So that is why the collection of lymphatic fluid there, the lymphatic fluid. Then if the fluid is collected into the interstitial space, that is called as edema. So that is why it is the swelling of interstitial space tissue as a result of lymph drainage failure when capillary filtration is normal. When the capillary filtration is normal, what happened? Again, the fluid formation will be there. The union of capillaries, arterial capillaries and venous capillaries there, no? When the union of arterial capillaries and venous capillaries there is a leakage of fluid there. So no, if when the lymphatic capillaries absorb the the lymphatic fluids, but there is an obstruction in the axilla. So that is why the edema, the fluid will be collected there. So that is called as lymphedema. So we we need to take the measurement. We will show you the next week how will we take the measurements, and we will take, and then the management part. Management parts, there are 4 ways of management: skin care, massage, bandaging, and exercise. This is the management of lymphedema. I hope Sister Regina understand something about lymphedema. Thank you. Any other question? So I have one. So one patient with CA breast with mets to peritoneal, EOG for one side is her vulva and noted to edematous, to the other side is not. Do this indicate there is a relation to lymphatic system? Yes, it is because of maybe the obstruction of the inguinal node. I think system, Michelle, any other problems these patients have? Any pedal edema? Any metastasis? Yes. Okay, no other limb swelling. Maybe because of peritoneal mets. So I think you can do the clinical examination. Based on the clinical examination, we will find out whether the patient is having lymphedema or not. If lymphedema present, you have to go for a lymphedema management part. You can advise the patient for proper skin care and advise bandaging. First, initially, we will start with a simple layer bandaging. So spiral bandaging. So you can start with a spiral bandaging if edema is less. If the patient is tolerated, then you can go for a multi-layer bandaging or the figure of 8, like figure of 8 bandage you can use. I think you can go and assess the patient. So please, is there any way we can avoid to prevent lymphedema? Any other answers from the participants? We expect the answers from the participants. Sister Regina is asking, is there any way to avoid or prevent lymphedema? Any other answers? No answers? Elevation, exercise, avoid tight clothing, like skincare. Any other points? Her question is, how will we prevent lymphedema? Any other answers? Good skincare. Okay. Uh, okay. So we can prevent lymphedema during the if the patient is underwent the total mastectomy. From the day itself, you have to teach the caregivers and patient about prevention of lymphedema. They do there's simple exercise like wall climbing exercise and okay, very good. And so you will teach the patient about the some simple exercise and skincare also. And one important thing you should highlight is they should not need not take any heavy weights. If they take heavy weights, what happen? So that will increase the circulation. Okay, if we carry heavy weights on that affected limb, that will stimulate our circulation. When the capillary filtration increase, what happen? Again, edema will be increasing. Okay, so and avoid to massage the massage also. Okay, so you can always educate the patient about the simple gentle massage. If you do good massage, we usually give massage for a bed sore prevention. That our goal is to improve the circulation. Here, if we improve the circulation in the interstitial space, what happen? Again, the capillary filtration is increasing. Okay, so they don't take any heavy weights and the affected lymph and that hot bath also. If they take hot bath, what happen? Again, the stimulation will be increasing. If the circulation is increasing, again the edema will increase. So that simple things you should educate them when after the surgery also. So that the simple exercise and if they have any proper skincare also. Okay, so if they are doing any gardening, they wear mosquito repellent also. Okay, so otherwise, if the mosquito bite, there is a chance of cellulitis. So that things you should educate the caregivers and as well as the patient. And along with that, you should explain if there is a small edema formation there, they will seek medical help as much as possible. If we care the first stage edema, then we will go prevent the second stage. So otherwise, if you don't take care of the first stage edema, definitely goes to second stage. It will be difficult to control. So we can move on to the patient story. Sister Nancy, over to you.
Hello, good evening, everyone. I'm Nancy, staff nurse from 23 Lodge Hospice, Kuching. Yeah, next slide, please. Today I'm going to present about my patient. This patient has passed on. So she was 48 years old when she was referred to us. This is a female patient diagnosed with advanced left breast carcinoma with bone and nodal mets triple negative, complicated with infected left upper limb wound secondary to lymphedema. So presenting complaints, she has mixed nociceptive and neuropathic pain. She complained of sharp pain over left upper chest with background of pain score 5 to 6/10. Her pain is usually aggravated by movement and prolonged sitting or standing. Left upper limb wound and swelling secondary to lymphedema. Occasionally, she will have contact bleeding of the left upper limb wound during dressing. She also has poor quality of sleep due to pain, anxiety, and afraid to mobilize her left arm due to pain and risk for bleeding. Okay, so history of illness. This patient was diagnosed with stage 3 disease in 2014. She underwent left wide local axillary excision, wide local excision and axillary clearance in May 2014. She completed adjuvant chemotherapy followed by radiotherapy until February 2015. Subsequently, she was under 3-monthly follow-up and yearly mammogram. In August 2017, she had local recurrence at the left breast wall with mets to axillary lymph nodes. Bone scan revealed bone mets. Patient was given few lines of chemotherapy. However, patient was admitted to the Sarawak General Hospital in April 2019 for bleeding from left axillary wound and pain control. Patient was also having left upper limb wound infection, and she completed augmentin for 1 week during admission. 12 days after discharge, patient went back to the emergency department because of bleeding wound. But patient refused to be admitted that time. She was counseled for best supportive care and was referred to 23 Lodge Hospice for home hospice care. So during our 4th visit for the examination, I break it into 2 parts: before crisis and when crisis happened. So when we first visited this patient on the 4th visit, she was ECOG 3, functional status wise was ECOG 3. She was alert, oriented to time, place, and person. All her vital signs were normal. She was still ambulating with 1 person assist. Movement made difficult by the swollen left upper limb and pain. Left upper limb was swollen, warm, and red, and the wound was highly exudate, patchy, sloughy with slight odor. So noted also there is contact bleeding, abdomen soft, noted mild bilateral pedal edema. What happened during the visit was, during the visit, our initial plan was to assist her in help her to have a shower. So in attempt to try to remove the dressing, she had some massive hemorrhage, and therefore this patient from ECOG 3, her functional status dropped to ECOG 4. So that was the time when the crisis happened during the visit itself. So this patient was having massive wound hemorrhage. When removing the dressing, we actually suspected blood vessel eroded. She started to panic and eventually delirious after realizing that the bleeding couldn't be stopped. Because she has lost quite a lot of blood, this patient became weak, drowsy, and pale looking. So at that point of time, this patient was ECOG 4. Can I have next slide, please? So what we did during the visit was we compressed the bleeding wound with gauze soaked with adrenaline solution in attempt to stop the bleeding. And for pain control, we tried to convert all her oral medication to fentanyl patch. At that point of time, the total conversion, she needed about 200 microgram per hour. And subcut morphine injection as needed as patient deteriorated. So management of pain and delirium, during that time, we did bedside titration of medication. So we have given subcut midazolam 2.5 mg. We gave it 4 times. Subcut haloperidol 2.5 mg. We gave her 1 time. And subcut morphine 10 mg times 1 were given in total. All oral medications were ceased. And we also explained to the family and emphasized on comfort care and oral care as patient was at that point of time is actively dying. So we started her with continuous subcutaneous infusion. The cocktail was subcut midazolam 20 mg plus subcut haloperidol 5 mg and subcut morphine 10 mg over 24 hours for terminal sedation. At that point of time, we also, apart from the CSCI, we also stand by with her all other injectable medications for EOL, such as subcut midazolam 2.5 mg PRN, subcut morphine 20 mg PRN, and subcut glycopyrrolate 200 microgram PRN. Next slide, please. So for psychosocial aspect, this patient was married and blessed with a son aged 21 years old. However, her relationship with the son was not close. The son had just graduated and recently moved out to stay with the grandparents due to logistic to work. The husband temporarily stopped working to care for the wife. He had hired a nurse to assist him with the care of the patient as well as to help her with her activities of daily living. This patient also had underlying depression under psychiatric follow-up. She was still on tablet duloxetine 90 milligram OD upon referral. During our first visit, this patient verbalized her wish to have a better relationship with her son. She also expressed her wish to go out shopping when she feels better. This patient knew that she was dying. She admitted of having suicidal thoughts, but she verbalized that she will not attempt to commit suicide. Patient has an elderly mother who still did not know about her prognosis. She was still struggling to break the bad news to her mother for fear that she could not take it. Next slide, please. So her medication before she deteriorated, when she was still ECOG 3 and able to swallow, she was on fentanyl patch 75 microgram per hour with tablet oxycontin 100 milligram twice a day, tablet oxynol 50 milligram BTP for the breakthrough pen. And for the neuropathic pen, she was having gabapentin 900 milligram TDS and tablet paracetamol 1 gram QID PRN. Tranexamic acid 1 gram TDS is for the bleeding. And then her laxative, she has tablet Colocil with Senna on night, suppository Dalcolex 2 PRN if she doesn't pass motion for more than 3 days. And adrenaline solution is for dressing in case there is some contact bleeding, then the husband will use it to compress and stop the bleeding. And she was also given tablet diazepam 2.5 mg on night. And after patient deteriorated, the end-of-life medication was as follows: continuous subcut infusion, midazolam 20 milligram plus haloperidol 5 milligram plus 10 milligram of morphine over 24 hours. She was patched with fentanyl patch 200 microgram per hour. and subcut midazolam 2.5 mg PRN, subcut morphine 20 mg PRN, subcut glycopyrrolate 200 microgram PRN. Next slide. And her main concern was severe pain. This patient, she has difficulty to move around, and most of the time she will be sitting there and difficult to fulfill her ADL, mainly because of the pain. She was also have risk for bleeding of the wound, and because of the site of the lymphedema, she has this high tendency to experience massive wound hemorrhage, which happened during our 4th visit. And the other concern is the psychosocial part, relationship with the son, and as well as how to break the bad news to the elderly mother. Okay, next one. So in summary, Madam A, aged 48 years old, was diagnosed with advanced left breast carcinoma with bone and nodal mets, triple negative, complicated with infected left upper limb wound secondary to lymphedema. She was under home hospice care for only 2 weeks plus before she passed on. Her main issues during home hospice care were pain, risk for bleeding from the wound, and psychosocial issues. All right, so for the discussion points, when do we want to start this patient with terminal sedation? How would you manage patient with suicidal thoughts or suicidal attempt? What can be done to help this patient with a psychosocial issue? How can we better be prepared for this scenario or crisis? For instance, massive tumor hemorrhage during home visit itself. Yeah. That's all from my presentation. Thank you.
Thank you, Sister Nancy. So if anybody would like to need any more clarification regarding this patient story. Anybody? Sister Nancy, we need a clarification regarding the patient medication history. Radhashmi, please go before this, the medication slides. Yeah, okay. So regarding the subcutaneous morphine, no? So 20 milligram. So the patient is on continuous subcutaneous infusion midazolam 20 milligram plus haloperidol 5 milligram plus morphine 10 milligram over 24 hours. Then again, subcutaneous morphine 20 milligram BRN. Then what is the why you are giving 20 milligram PRN dose? The patient is.
You mean the PRN doses?
Okay. The patient. Usually, we prefer the same dose as a rescue dose. That is why I am asking.
Why we're giving the subcut continuous subcut midazolam 20 milligram, is it?
Yes.
Sorry, your question.
Yeah,
okay.
The
Because
patient is on 10 milligram morphine 24 hours. No, on continuous the subcutaneous infusion. My question is, why you give 20 milligram PRN dose? Why you choose 20 milligram PRN dose? So
the PRN dose is actually 2.5 milligram subcut midazolam.
Not midazolam. I am asking about morphine.
Oh, morphine. Okay, because this is actually the breakthrough dose is slightly lower than the total dose needed, because the subcut injection line, the maximum dose that we can give is 2 mils. So 20 milligram of subcut morphine is actually 2 mils. So when we give the maximum dose plus flushing, it will be more than 2 mils. And if we give more than that, the line will not be good. Yeah, because of the subcutaneous injection, that's the maximum dose that we can give for breakthrough dose. Is it understandable? Meaning that, yeah, the fentanyl patch is 200 plus morphine 10 milligram in the continuous subcutaneous line. The breakthrough dose is, if calculated, is supposed to be higher than 20 milligram, correct? But the reason we give 20 milligram for breakthrough dose is because for the subcutaneous line, we cannot exceed it about 3 mils. So at one time, we only can give less than 3 mils of medication through that port that we insert on the patient, the injection port. Yeah, so if we give more than that, the line might be spoiled, or it will not be functioned, or it will get bump. So that's why our doctor recommend at maximum dose, which is 2 mils, that is about 20 milligram.
So why you choose the same, the strong opioid, like two opioids, no, morphine and fentanyl at the same time, at the same time?
Okay, the fentanyl patch was applied because this patient could no longer able to swallow. Sorry, this is before she deteriorated or after she during the actively dying period?
Okay, what we do here is once we switch on to the from morphine to fentanyl, we keep the patient in the fentanyl patch, and if the patient is having intermittent pain, we choose morphine for the rescue dose. That is what we practicing here. Once we switch on to the fentanyl patch, we stick on the fentanyl patch. If they have any rescue in between the breakthrough pain there, we will choose rescue dose. That is we keep the morphine for that. So
Sorry, I didn't get you.
usually what we do here is if a patient is on morphine, when we switch on the switch on from the morphine to fentanyl patch. Okay, the fentanyl patch will be continuing, but the morphine will be the regular dose will be we will stop the regular dose. In addition to the regular dose, we will that if the patient is having breakthrough pain, we will give morphine.
Yes, that's what we are giving. When this patient have she has fentanyl patch on, so if she has breakthrough pain, she will the carer will need to give the subcut morphine PRN for the breakthrough pain. So that is for the end of life medication. But before she deteriorated, when she is orally tolerating, her breakthrough medication is oxynom. So that's why she has this tablet oxynom of 50 mg for the BTP.
Oh, good.
Yeah, oxynom is similar as it's just something like oral, like tablet MST. It is still opioids. Yeah, it's a fast acting. So when she deteriorated, and then when she couldn't swallow, we switched the medication to subcut morphine for the breakthrough dose.
Okay, thank you. So we can move on to the discussion points. So when do you start patient with terminal sedation? So I'll expect the answers expect from the participant side. When do you prefer terminal sedation for a palliative care patient? Anybody?
If the symptoms are persisting, in all medicines we are trying to give, the symptoms are persisting means we can start the terminal sedation with taking consent from the patient side. Before that, we have to explain more detailedly about the palliative sedation. It is used only for the symptom management Like that, we have to explain them about palliative care sedation.
While we choose terminal sedation, we call it as refractory symptoms. Refractory symptom means we are not able to, the patient has more than one symptom, but the symptoms are not controlled with our medications. So that time we choose the terminal, we prefer terminal sedation. But if the patient is not willing to accept the terminal sedation, we are not that giving the terminal sedation. The thing is, our idea behind that is when we choose the terminal sedation, this is for the symptom relief. Okay, so if the patient is having more distress about her or his symptoms, that will be controlled with the help of some medication, some sedation, that is called terminal sedation. If you choose this, you have to explain very well to the patient and the family about that. Okay. The next question is, how would you manage the patient with suicidal thoughts or suicidal attempt? This patient is already on psychiatric medications. So any other idea? Any other points? Nurses, please talk. Psychological support. Any other points? Any other points as a nurse we should keep in our mind when a patient with a suicidal thoughts? How will we manage? Ensure the patient is left alone, should be closely monitored. Very good. Counseling. Any other points? Counseling again. Very good. Never leave the patient alone. Have someone watch her. Keep sharp away, or anything can be used to harm herself. Okay. Very good. Emotional support. Remove all the harmful articles or instruments from surrounding safe environment. Give safe environment. Psychiatric consultation. I think the patient is on already did the psychiatric consultation on medications also. Any other points? Very good points. Very good comments from the participants. Anyway, as you already, as you all said, this you need a frequent psychiatric consultation, and we need to watch the patient that closely. And if maybe because of depression, the patients may think suicide. I think you can manage the depression. First, better you can refer the psychiatrist and take the treatment from the psychiatrist. If you the thing is from the nurses part, we need to assess the patients. Okay, if the patient is have any depression, if our role is to assess and find out whether the patient is having any suicidal thoughts. If there is a suicidal thoughts or attempt, any attempt also, if they did any suicidal attempt, that also we need to find out. If they if if after you find out all the problems, you need to discuss with our team, and you can refer to the patient to the psychiatrist. That is the way we will manage for a this type of patients, and you can give a proper counseling also. You can try counseling first. Otherwise, you can refer to the patient. Okay. Okay. And the third question is, what can be done to help this patient with her psychosocial issue? What will you do if the patient is having any psychosocial issue? Family conference. Very good. If possible, arrange family conference. Okay, you can try to involve the whole family members that when we conduct a family meetings. Nurses always busy with other works also. If we find out psychosocial problems, what we can do? First, we can assess the psychosocial issues. Okay, identify the needs and identify the needs. If they identify the cause. So if they have any psychosocial issues there, you can go and listen, identify the problems. Okay, so when we identify the problems, what we need to do is, if medical social workers are there, you can refer to the patient to the medical social workers. I think they will be taking history more than us. They are trained with the more assessing the psychosocial part. So I better you can refer the patient to the medical social workers. Otherwise, you can give a proper counseling also. If you identify the psychosocial issues are there, if you can give, you can try to correct the correctable. For example, if they have any family issues are there, you can maybe conduct a family meeting, and you can try to solve the problems. Okay. Then if that issues are not solved, you can try maybe refer to the counselor or a better part. So, and the fourth question is, how can we better be prepared for this patient, for this type of patients? For example, massive tumor hemorrhage during home visits. If you can imagine, you can go go visit the home visits. That time the patients develop massive bleeding. So, how will you manage? That is the question from sister. So I think we will discuss during our fungating wound management time. We were discussing how we will manage with the patient with hemorrhage. I think we will discuss it again here. Okay. Points, please. How will you manage? What instructions will be given to the caregivers and patients about that? Answer, please. Again, nurses. This wound is always managed by the nurses. So I think all the nurses will know how will we manage the patient with bleeding. Okay. So let this. Okay. Any points? Nobody have any idea about it? Gentle pressure directly. Very good. If bleeding there, you can try to apply gentle pressure on it. Okay. Any other points? If you give a gentle pressure, that time the bleeding is not controlled. What will we do? Okay, apply dry pad can be applied on pressure applied by. Okay, when we apply the gentle pressure, you can always use it as a dry pad. Apply pressures to stop bleeding, then cover on bandaging on the area. Start with a dark color towel, pressure applied. Very good. Use green towels. For what? Why we are choosing dark color cloth or green towels for mopping the blood? To avoid panic. Okay. So, and one more answer: proper assessment during each visit, anticipating the bleed and taking the required articles, or even train the family members to the intervention. Okay. Yes. If you give a dark color cloth or like a green color cloth, if the patient is having severe bleeding, so that will prevent panic. Otherwise, the patient and family members will be anxious about that things. So better they can choose a dark color cloth. So this is one of the important thing. If there is a chance of developing bleeding there, so if there is a potential for complication for there, especially head and neck cancers, so there is a chance of bleeding anytime. So maybe the patient's death because of bleeding. Okay, so we need to prepare the patient family about that. So always when the bleeding they when occur, so always they can use the dark color clothes. Okay, that is the one important thing. And as or the if the bleeding the not profuse, so simple bleeding there, you can always go with the gentle pressure on that area, that that bleeding will subside. If your that bleeding is not subside, better you can apply sucralfate powder or tranexamic acid also. Okay, you can make it a crush it and make it a powder and spread on over that. And if that bleeding that time also bleeding is not controlled, you can go for systemic medications. And if the patient's condition is okay, you can refer the patient to the radiologist also. So if the radiologist, if they take on cycle of radiotherapy, that after that maybe there is a chance of shrinking the tumor size. So that will prevent bleeding also. So that is the management of bleeding things. Better you can prepare the patient and the family for that, not the patient. You will give an idea about if they you can give an idea about this to the patient anytime. So bleeding will be occur. So that management will be done by the caregivers. You should prepare the caregivers for the same. So any other points you want to discuss? Okay. I think we all covered almost all the points here. I think we have a practical session on the next Monday. That time we will discuss more about it. Anyway, thank you all for the active participation for this today's session. Thank you, Sister Sreedevi, for the excellent presentation. Thank you, Sister Nancy, for the presentation. We learned more about from your case presentation, and we discussed more about the discussion point times. We learned more about the things. I hope all of them are understand well. Anyway, thank you all.